Hey everyone, this is Andrew Boland, your Assistant Medical Director, here to discuss a few QA issues and provide a little bit of feedback for everyone just from listening to 911 calls over the past few months. So let's talk a little bit about why this matters, why we as medical directors are involved in doing 911 QA. Although every medical emergency is important, certainly one of the medical emergencies where we make the biggest difference as telecommunicators is in cardiac arrest. As you all know, minimizing time to CPR and defibrillation is key for survival. Every minute without CPR and defibrillation, generally speaking, is a 10% chance off of your likelihood of surviving. And even though this graph here starts at 100%, as we all know, usually our chance of survival doesn't start at 100%. Usually it's much lower than that. Every single second matters in terms of identifying the cardiac arrest, quickly dispatching the cardiac arrest, and providing quick instructions. And that is part of why this is so important and why we are providing this QA feedback for you. In addition, as all of you know, one of the most important pieces of information, if not the most important piece of information that we get as telecommunicators, is the address. And we have been doing a fantastic job with that. Not only do we ask off the bat, pick 911, was the address of your emergency, but we also have been doing a great job at not confirming the address using leading questions. So simply having the caller repeat the address. The reason that's so important is because when people are excited, freaking out, whatever the case might be on the other line, a lot of times if you simply repeat back an address and repeat back the wrong address, they will just say, yes, that's correct. And there have been several cases of this. Here was one that was back in February where they had an infant in cardiac arrest and they confirmed the address incorrectly and ended up sending the ambulance to the wrong address, and there's a delay in response, leading to a bad outcome for this baby. And there have been several similar cases in other jurisdictions, and that's certainly something that we never want to happen to any of you. So fantastic job on what you guys are doing with confirming the address, not using leading questions. So let's go into some specifics about feedback. So one of the things that is really important in terms of getting the correct information and making sure we're moving quickly through EMD is really sticking to the script and trying our best not to deviate from that. So what is the address of your emergency? Getting the phone number. Tell me exactly what happened. There is sometimes a tendency when we get a call and you ask for the address and the person starts spewing it out of live information to, instead of asking, tell me exactly what happened, just kind of ask a leading question like, so you said he's having trouble breathing? But really, unless it was clear off the bat, hey, this person is unconscious and not breathing, going through the questions again of tell me exactly what happened is important. I'll tell you about one case that I came across a couple years ago where we had a situation like that. Hey, here's the address and he has chest pain. And well, we appropriately went down the chest pain protocol, but we didn't recognize that he was shot in the chest, and that's why he was having chest pain. He just said, no, well, what's the address for emergency? Well, here's the address, and oh, his chest is hurting real bad. And instead of asking, tell me exactly what happened, we went down the chest pain protocol off the bat, and our providers ended up walking into an unsafe scene because we didn't realize that we were responding to a GSW to the chest. But just importance, regardless, sticking to the script. It's so important for cardiac arrest. I've noticed those cases where we deviate from the script, we end up inadvertently causing delays in CPR instructions. So sticking to the script is always important for that. Another item that I wanted to touch on is obtaining the phone number. So I think that it's totally appropriate when we don't have the phone number auto-populated and available to us, to ask, hey, what is the callback number in case we get disconnected? But I really like when you all have that number pre-populated and identify that and go straight from Pitt County 911, what is the address for your emergency, to tell me exactly what happened. Because when we already have the phone number, that is one less step to getting to identifying a cardiac arrest, dispatching a cardiac arrest, and giving CPR instructions. And in those cases where the number is pre-populated, I think going ahead and asking the address at the end of the call before you disconnect so that we kind of check that box is perfectly appropriate. Obviously, when we don't have that number available to us, going ahead and asking it like we normally do, going through the EMD case entry questions. But when it's available, let's go ahead and skip that question, confirm the address, then tell me exactly what happened so that we can move on to identifying cardiac arrests and other time-sensitive emergencies. I also wanted to talk for a second about asking names, because there are times when knowing a name is appropriate, but generally this is not something that is in EMD. EMD case entry is address, phone number, tell me exactly what happened. Nowhere in there is there an instruction to ask the name. Now, certainly asking a name is important when you need to comfort somebody, and at some point in the call, you probably do need to ask the name. But I don't want us to get caught up in asking a name, because sometimes, one, people don't want to tell you their name. They get caught up in spelling it. Maybe you misheard the name. And anytime we get into asking a name, it ends up just leading to a delay in identifying a cardiac arrest and providing instruction. And the name really isn't that relevant for the patient's medical care. So I think it's fine to ask a name if you need to calm someone down, but otherwise I would leave asking a name for the end of the call before you hang up, just to kind of check that box. But generally for medical calls, what's the address, phone number, tell me exactly what happened, and go through the script, and don't get caught up on asking the name. So attitude is something that we have really been getting better at in terms of our customer service. And I know that it is so difficult sometimes to not raise our voice or react to some of the callers on the other end of the line, because they're yelling, they're cursing, they're getting frustrated with you, and I know that it's very hard not to get frustrated. But even if you do get frustrated, try not to let it show. Stick to the script. Continue to give firm instructions, because really getting frustrated adds nothing to the care of the patient, adds nothing to the call. Make sure we're staying calm and taking control of the situation. One thing that certainly helps with those frustrating callers is the concept of repetitive persistence, which I know you all remember from taking EMD, but repeating the instruction in a firm voice. Don't worry about the fall. We need to help him now. Don't worry about the fall. We need to help him now. Pull the sheet under him. Whatever the case is, continuing that instruction in a firm, clear voice, even when the person on the other end is frustrated, they're pushing back. Just continue to repeat yourself and give firm instructions so that you can move on to the next step of helping that person. One other thing that I've noticed us doing recently is not committing to CPR instructions all the time. And what I mean by that is, once we have decided that the person is unconscious, not breathing, or unconscious and not breathing effectively, I've listened to many cases where it seems like we are questioning, well, should we actually be doing CPR? Did they just say that the person was breathing again? But I think it's really important that once we commit to doing CPR instructions, yes, it's fine if they volunteer, oh, hey, he's now awake and like breathing and talking. Okay, obviously that's a case where we can go ahead and stop CPR instructions. But otherwise, when we're getting to the point of we're putting hands on the chest, we are telling them to push hard and fast in the center of the chest, continue down that route. Generally, as you know, there's very little harm that can come from chest compressions, and it's always better to just go ahead and do the chest compressions, go ahead and do the CPR, than stopping. I know that it's very hard over the phone, and we sometimes get some self-doubt when we are getting to that point of actually giving CPR instructions. But trust me, I will always have your back when you are giving CPR instructions, when you're following the protocol. So once you get to that point, go ahead and commit to it. Continue the CPR instructions unless something drastically changes. The person wakes up, the person's obviously breathing, the person's talking, etc., etc. There are a couple of specific cases or situations that I want to go over. The first is a person who is unconscious in the vehicle, whether it be in a parking lot, in the street, at a stoplight, stop sign, whatever the case might be, or someone unconscious on the side of the roadway. That is an EMD call, an EMS call, and these calls should in no instance be transferred to police. We need to continue down the EMD pathway. Are they alert? Are they breathing? And try to get as much information as possible and send that call to EMS. Going along with that, cases where the caller is refusing to do chest compressions, I know can be incredibly frustrating, but these are also cases that should not be sent to police. These are cases where we need to use repetitive persistence, do our best to continue giving instruction, even if it means continuing to repeat yourself. Never should we be threatening a caller with, well, if you don't do chest compressions, I'm going to just send you to the police. Well, if you don't listen to me, I'm just going to send you to the police. That never gets us anywhere. That is a lost opportunity to be able to give instructions. I know that these calls can be frustrating sometimes, but doing our best to continue giving instructions is really important. The other specific case that I wanted to go over was cardiac arrest victims who are cold. So I think it's important to point out that almost every cardiac arrest victim is going to be cold. Very rarely are cardiac arrest victims going to be warm. Think about it. When you have someone who is in shock, say that they've lost a lot of blood, they're septic, whatever the case might be, usually they have pretty cold extremities even before they've lost the pulse. So cold by itself does not mean that they are beyond any help. So whenever you hear the caller volunteer that the victim is cold, that does not mean we go down the expected death route. Tell me why it looks like they are deceased. We go on, stay on the line. I'm saying the paramedics now. I'll tell you exactly what to do next, and continuing down the cardiac arrest CPR instruction route. Cold and stiff is different. Cold and stiff is beyond any help, but cold by itself is not the same as cold and stiff. All right, well, thank you for your attention. Hopefully you found this to be useful. Certainly, if any questions, comments, concerns ever come up, I'm more than happy to chat with any of you. This is my email and phone number. Send me email, phone call, text, anytime. More than happy to help in any way I can. So thank you again, everyone, and take care.